Okay, perfect. So this is all of us in the meeting now. Welcome everybody. We were just having a couple of technical issues before we came into this meeting. I'm just going to update a couple of settings just to make sure that you can all, if you want to unmute or put your hand up. So just bear with me 1 second. Fab. Okay, so welcome everybody, and good morning. It's a nice sunny day. This is our second instalment of a series of question and answer sessions delivered on behalf of Aberdeen City's Child Protection Committee. My name is Amy Anderson. I'm the lead officer for the CPC. And my role within the CPC is to help drive interference. If I can just ask everybody just to mute the mics. There we go. Thanks, Dawn. Yes, so my role is to help drive strategic improvement activity across the partnership. If you were unable to attend our first Q&A on physical abuse, you can watch it on Aberdeen Protects. And as I've said in the sign-up link, when you registered for this event today, that the purpose of these Q&As is to enhance practitioners' understanding of each other's roles, address any unrealistic expectations, and to dispel any myths related to areas of practice and concerns. The format of today's session and in future will be very much led by you and what you feel works best in terms of these Q&As. And if there is any area of practice that you'd like to see covered in future sessions, please let us know. Either drop it in the chat or you can email me separately. Like I say, we want to make sure that they are of value to you. Today's Q&A is around child protection and neglect, and we've got a panel of representatives from across the partnership to answer some of your questions today. So we'll just do a quick introduction of the panel. And so Fiona, I think I'll start off with you. If you just want to introduce yourself, please.
Hello everybody, I'm Fiona Miele. I'm lead nurse for child protection for NHS Grampian.
Thanks, Fiona. And Sarah?
Hi, I'm Sarah Jarvis. I'm a consultant paediatrician in child protection in the Aberdeen Children's Hospital.
Thank you. And Marie?
Hello, I'm Marie King. I'm a team leader here at the Children's Reception Team of Children's Social Work.
Thanks, Marie. And Anne?
Hi, I'm Anne Matthew. I'm the team manager within the Children's Reception Team.
Thank you. Lisa?
Hi, I'm Lisa Williams. I'm one of the Quality Improvement Officers for Education, and I lead on child protection and safeguarding for our education colleagues.
Thanks, Lisa. And finally, Mark.
Yeah, morning everyone. I'm with Police Scotland. I'm a detective inspector in the Public Protection Unit based in Aberdeen.
Brilliant. Thank you very much. So today we chose neglect as our theme for this session. And this was for a number of reasons. The first being that over 50% of our children on the Child Protection Register here in the city are registered under the category of neglect. And without undertaking a case file audit of all of those children, I can't tell you what type of neglect that is, what behaviours or environments are sort of leading to that category being selected. However, what we do know is that within the Child Protection Register, that most of the children who are registered under neglect usually have more than one concern. So the children can be registered under multiple categories and are usually accompanied by something like physical abuse or parental mental health or drug use. Secondly, over the last couple of years, the CPC have undertaken some self-evaluation activity, mainly in the form of an audit. We did an audit a couple of years ago around identifying and tackling neglect in the city. This then resulted in a neglect resource toolkit being developed to support practitioners working with families where there are indicators of neglect. This resource toolkit is available on Aberdeen Protects. And some of those resources included information about medical assessments, exercise and professional judgment, and courageous conversations with parents and carers. Just going to mute somebody. Sorry. Most recently, in the last few months, the CPC have considered options for an assessment tool for neglect. We looked at the graded care profile, which you might be familiar with, and other home conditions tools used by other local authority areas. And on behalf of the CPC, our neglect thematic group, which is chaired by Lisa here today, are in the early stages of developing our own version of a family strengths and needs assessment tool. And our vision for this tool is that it's through a preventative lens. It'll be aligned with the national practice model and the indicators of neglect. So moving on to today's session, just to clarify, this is not a training session, but rather a place for us to have a conversation about our multi-agency response to neglect. We want to encourage discussion and respectful challenge around existing ways of working. So we'll get started, and what we'll do is we'll start off with some questions that were submitted through the registration. If we haven't answered your question in this session that you did submit, we'll make sure that we get back to you separately with a response. And towards the end of the session today, we'll drop a very quick feedback survey in the chat. And I'd be really grateful if you could just take a moment to fill that in, because it does help with the shaping of these sessions. During the Q&A, please feel free to raise your hand or drop a question in the chat. Let's say we want it to be engaged and productive. So we'll get started. So I'm going to start off with our first question, which was from a health visitor. And a health visitor said that it's sometimes a challenge to get children's social work to understand our concerns about a child being neglected or at risk of neglect. And they want to ask a question about how these challenges might be overcome. So that's our first question. And Fiona, I'm going to come to you first to start us off, and then Anne, please. Thank you.
Thanks, Amy. Yeah, and this is a very familiar question. You know, it's something that we hear all the time. It's something that's raised to us all the time and often is escalated through our own health processes to say that, you know, there is some sort of frustration, concern around health visitors not being able to maybe articulate. Well, it's not that they're not articulating, but it's that communication between themselves and other services around sort of thresholds of neglect. You know, the specialist nurses for child protection will often get this question as well. And, you know, what we will always say to practitioners is, whilst, you know, they're recognising neglect, the important thing around that is to have a really good assessment of what we're seeing. So we can't really articulate what we're seeing unless we do a really robust assessment about what we're seeing. Of course, we've got the national practice model. We've got all those tools of assessment that help us to make that assessment. The important thing is the analysis and then the plan. We think about GIRFIC in its widest sense. And of course, as a universal service, health visitors are getting in there at the earliest possible time. So they're the people that are often identifying the start of neglect process, or should I say they're in at the start of identifying that neglect. So really important to use those tools. We've got those tools. It's a shared language. We all understand what we're talking about when we're talking about the national practice model. And, you know, we start off with the 5 GIRFIC questions, and we, you know, that's where we start, and we move on through the assessment tools. So what I would say is, have the conversation. Really, really important to pick up the phone still and have those conversations with our social work colleagues about what our concerns are, but have that robust assessment behind us to say, you know, I've considered this. This is what I've done already. These are the things that I've tried, and I'm not seeing any change, and I'm not seeing an improvement in this child's circumstances. And I think when we have that shared language of going through an assessment process, our social work colleagues then can say, oh, I can see the journey that you've gone through, and I understand now that you need our service to support what you're doing. So I don't know if there's anything, Anne, that you want to add to that, or Marie, that you want to add to that in terms
You've
of.
captured it exactly the way I would have said. It's about that early intervention and capturing the assessment, and there is a reason we ask for that as well. Apart from what you've explained, it helps us understand that we need to come in. It helps us understand what has been tried. It helps us understand what journey the family have been through and why we need to come in. But equally, there are times when we need to maybe take it further, where we come in and we're finding that we always work voluntarily. We don't have legal powers until we seek that. So when it comes to the point that we're thinking we've come in and we want to try and help, and it's not working on a voluntary basis, and we need to go to the reporter, that evidence coming from the health visitor with the evidence that we are able to capture all helps us then get that legal measure we need to maybe make things better. I'm just speaking about the wide spectrum, but then I think you've covered it all. When we have a robust assessment, when we have a chronology that says, I've attempted this many times to visit to address, we then absolutely get it and understand. There may be times that, we're still sitting at different kind of levels, and that's when we have conversations. And I think that has worked better more recently. It may be there are the odd occasions where you need higher intervention, but in general, I think you've covered it all. But that evidence building and capturing does not start at social work stage. Actually, it starts early on if we need it further. But thank you. That's all.
Great, thanks, Anne. Thanks, Fiona. From the rest of the panel, is there anything that you'd like to add? Yeah, Lisa, go.
Yeah, Amy, I'm happy to add in there as well. I suppose the education's part within that early intervention is really important. We talk about this at every panel meeting and every time we have child protection coordinators together, and I can't stress it enough how we're one team and we need to work better as a full team. And I think we've made huge strides in doing that over the last few years, and we need to continue to do that. So those conversations are really important, but actually our role has changed as educators, particularly senior leaders in the education team over the last few years. And what would have been considered well, that's health's job, that's social work's job, and it has changed, and it should have changed just because of, sorry, I'm in a school and the bell's just gone. I don't know if you can hear that. And so the point I want to make there was really just that early intervention is really important from our perspective too. Quite often it's the school leaders or the teachers that have a really strong relationship with the parents, and therefore those early conversations around, are we finding things difficult at the moment? Is there a financial strain that's new or increasing? Is there something we can collectively do to help? And having those early touching base, light, gentle conversations to start that process, if the relationship is strong, is really important and can really help to make things, to make sure that they're being advised appropriately in terms of financial supports, etc., in that early stages. So I suppose I just wanted to emphasise that we've all got a role to play in terms of that early intervention.
Great, thanks, Lisa. Anything else from the panel on that question? No, not seeing any hands or any questions in the chat just yet, so we'll just keep moving through, and like I say, if you want a follow-up question to any of these responses, please just raise your hand. Moving on to question 2, we have a question: how can we empower practitioners to have more confidence to talk about neglect with families, especially in sensitive areas like obesity or emotional neglect? So Marie and Anne, I'll maybe come to you first, either one of you, just to start us off from this, and then perhaps Sarah after that.
Marie, do you want to go?
I was going to say, do you want to go with that one?
Yeah, again, I suppose, and here we come back, and we might sound like we're a stuck record here, but we come back again to starting those conversations early. I'm hoping that we're not just throwing the word neglect as a standalone conversation with a parent who says, oh my God, I don't. For example, we've had, despite conversations starting early, we go to child protection planning meetings, and the minute the child is registered on the category of neglect, they say, but I give them clothes, I buy phones, I do that. So it's about tackling their understanding of what neglect is. And it's not a standalone conversation. It's, again, I know it's difficult to have the conversation But if you're following, like Fiona, following the steps of the GERFEC model, where you're starting that early, Fiona's already spoken about, having those meetings and capturing it within written documents. Doesn't have to be lengthy documents, but something that the family can read and understand. You've had meeting this month. You've spoken about this needing to get done. A month later, it's not been done. A month later, it's not been done. So what that then means is that this need is not being met. So you're kind of evidencing it to them. It's not easy, I know, but you're taking them through a journey as opposed to saying, oh, you're neglecting the child. And we speak of neglect as, it's the persistent failure to meet a child's medical, educational, the definition by heart. Sometimes you can have an episode of neglect, and that doesn't mean it's persistent. You can have an episode of neglect. I'll just give you an example. We got recently of a child who was left unattended at home, and he decided, he's 11 years old, and thought, okay, I'll cook something for myself. And what that resulted in is the fire service being called because the smoke alarms went and he set fire to a pan. And that was neglect. That was neglect. That sometimes you're faced in a situation where you have to discuss, you've neglected the child's need to be safe, to be supervised. But it was not persistent because the parent absolutely got it and it has not happened again. So yes, we talk of persistence, but again, the answer to that absolutely is you're not having a standalone conversation unless it's a situation like this. You're starting that journey early with the parent and then taking them through that. And then obviously you're again coming from a place of concern for the child, and that needs to come through in your relationship and conversation. It's not about blame. Parents will still feel that. I don't think there's any taking that away from them. That sense of shame and guilt will be there. But I don't know, Marie, if you want to come in and you have something else you want to kind of add to that.
I think you've covered that all, Anne. Thanks very much for that.
Thanks. What about, Sarah, I'll come to you, but also just thinking about practical steps and how we can support families to make those changes. So it's identifying and recording and things like that, but actually making the changes can obviously sometimes be very difficult. Sarah, I'll start off with you and then, like I say, anybody jump in, please.
Yeah, I think the obesity thing is becoming a bigger and bigger issue, and it's no pun intended, and it's a really difficult one to tackle because it's such a sensitive issue. And I think what's really important is, again, like Anne and Fiona have been saying, it's the documentation of the discussions that you do have before we start calling it neglect. And it's always by starting with highlighting concerns about a child's weight, regardless of whether there's a child protection connotation to it. And by the time patients come to see me, often it's, oh, I'm fed up of hearing from so-and-so about their obesity and I think she looks fine. Just emphasizing it, yeah, your child looks fantastic. However, what we've identified is that obesity is something we need to consider and how you raise that. The majority of patients that come to us with childhood obesity bring with them obese parents. And what we do know is parents are morbidly obese. So, BMIs of 35 or more will all have some symptom that's associated with their obesity. And it's the best way into to getting engagement from parents is sometimes just to ask for their experience and say, are you worried? And, I recognize that sometimes, families can all struggle with weight issues at the same time in a really non-judgmental way, and invite them to share with you what their own struggles are, and then start to recognize what the struggles for their child might be going forwards. And then most importantly, document that you've had that conversation so that when this does meet that threshold where you're calling, Anne and Marie and their colleagues, that parents aren't going, well, why has nobody said this to me before? Because inevitably that is always a comment that comes back to us. Well, nobody's addressed this with me before. Why am I getting child protection now? And it's just really clear documentation. On this day, so-and-so is present. This is what I said. Mum showed understanding of what was being said. And then the second part, Amy, is your address about helping families to make changes, because we know that currently within Grampian, we do not have the dietetic service that children need for obesity. We're a lot like CAMHS, we're just skimming the very top of the worst children that are already severely affected. So there's very little preventative action that is being supported at a tertiary level. But just recognizing some of the really simple things that I think in the next 20 years are going to become really key is the ultra-processed diet. We're just in the early stages of this now. In about 20 years' time, we're probably going to have warnings on health, on food items that we see on cigarette packets today. And just helping parents to understand, you know, tiny changes. We're not asking people to put their children on a diet, but recognizing that lots and lots of ready meals, ultra-processed foods, they automatically are linked with obesity. Helping parents to understand that it's really expensive to eat well, and small changes like just reducing portion sizes, recognizing that foods that children have to chew are more likely to make them feel fuller earlier than foods like chicken nuggets that you barely have to chew, and therefore you don't get any of that satiety that we get from whole foods. And then just recognizing that you can signpost. School nurses are really good. We have got information leaflets that we can hand out to parents, and just the early changes. And obviously we've got the active schools throughout Aberdeen and Aberdeenshire as well, just to help children get back on their feet and away from their devices. And it is a really difficult one. I haven't tackled neglect, Amy. I don't know if you want to come. You want me to let Lisa come in and then come back to the neglect side of things?
Yeah, Lisa, do you want to jump in and then back to?
Sure. It was really just to point out two elements. One, I've put in the chat the neglect toolkit that Amy mentioned earlier, and there's a really clear document within there about those courageous conversations. So for this less experienced school leaders or less experienced members of our health and social work team, it's a really helpful document to review and to consider as a team. And the other point to make, Amy, was that we have created a video called Naming Neglect. That's a multi-agency video that will be circulated at some point soon. So again, it's something to maybe discuss with your team and help to encourage that professional conversation around what you need to consider as a bit of a script before having what is quite often a very difficult conversation.
Thanks, Lisa. Sarah, I'll come back to you. Is there anything further that you'd like to go into just now?
Yeah, just on the neglect side of things, we obviously often pick up a lot of neglect just incidentally in health, and it's that courageous conversation. But again, starting with parental understanding and highlighting exactly what you've noticed. So I've noticed that Johnny's top is quite smelly and quite dirty. Is this something that you've been struggling with, rather than launching straight into this isn't good enough and this is neglect? And once you've listed all the things that you've noticed, as you pull parents into that conversation, it's being able to describe neglect before using the term. It's a bit like when you're breaking bad news to families about a diagnosis of cancer. As soon as you say the word cancer, people stop listening about what the diagnosis actually means. And neglect is very similar. So it's just describing what's not good enough and why it's not good enough, and how parents have ended up there, what support they needed, and then saying, well, what this means when children don't have all their needs being met is that there is a neglect of their needs being met, and when we identify neglect, we can support you, and we can help you to get there and champion you guys as a family. So just a very non-judgmental approach.
Thanks, Sarah. Mark, do you want to come in?
Yeah, just a quick one. Certainly on behalf of the police, we normally come in after early intervention, I suppose, has failed. And I suppose it's just a reassurance to everybody on here that we are not there to investigate you as individuals. We're there to investigate the whole circumstances that's led to the concerns around that child. And, from being involved in several of these types of inquiries, I think it's so important that those difficult questions are asked early on and the answers are documented, and don't assume that somebody else will do it. With all the kid going to school and the kid's not maybe appearing scruffy, and they think that somebody else will follow that up. I'm certainly aware of it, although he wasn't a child, he was an adult, where an adult was at university. He's then gone to his GP, he's then gone from his GP into the hospital. When he appeared at hospital, staff raised concerns that his mental health wasn't quite correct, he was smelling, just generally not, his general appearance was not good. And the person that saw him at the hospital raised the fact, has this been raised with anybody? And she went down the line and went to the GP, went to the consultant, went to education, and it hadn't been raised. They all had concerns, but everybody thought somebody else would deal with it. And this kid had got parents down in England, and you can just put yourself in that position. If that's your child and they're away from home, who's making that decision to look after that kid? So it just emphasizes that don't assume that somebody else will do it. If you've got that gut feeling that something's not quite right, raise it and ask those difficult questions.
Brilliant, thank you. Thanks, Mark. That's really helpful. I've got a question from Gooch in the chat. Gooch asks, has there been any analysis undertaken of the correlation between those children on the Child Protection Register to aspects such as deprivation? I can probably answer this one, Gooch. We've started to look at this. We have the CPC has a performance and quality assurance subcommittee, and we look at lots of different indicators, data indicators for child protection, and one of those is we started off with a heat map of children on the Child Protection Register, and what we've just started to include is the percentage of children and what percentage quintile in the SIMD. So we haven't dug further into that yet, but it definitely is something that's coming up, and we want to explore a little bit more. But just as a bit of a flavour, in May this year, 33% of children on the Child Protection Register are in that first quintile, with 13% in the second, and moving through to the third and fourth, 4% in the third, 33% in the fourth, and 12% in the fifth. So it's a helpful to raise that, and just a bit of assurance that is something that we're looking to explore. And we have got a question. In fact, our next question is about poverty and neglect. So the question that we received through the registration was, what are some of the effective ways to differentiate between poverty and neglect, and how can we address the underlying issues without stigmatising families? So Fiona, I'm going to pick on you for this one first, and then let's say a discussion between the panel, Marie, perhaps Marie or Anne. But yes, Fiona, do you want to start us off?
Yeah, and this is a really important point, I think, when we're working with families who are experiencing poverty. It's our understanding of the fact that, you know, families that are living in poverty absolutely do not necessarily neglect their children, but we also need to acknowledge that a lot of the children that experience neglect, poverty is a feature within their lives. So there's a really distinct difference there. So not all children live in poverty experience neglect, but for those children who are neglected, poverty is often a feature within their lives. Not always, but the majority certainly are. And I think the thing about it is, just like you said, Amy, it's about making sure that when we're working with families, we're doing it in a non-judgmental and certainly not a stigmatizing way. Families live in poverty for all sorts of reasons. It's around life chances, it's around things that have happened to them, it's around illnesses and all sorts of reasons why families may experience poverty. And what I think is really important for us to understand is that sometimes it may lead to what we consider to be neglectful situations, and often unintentional. So, for instance, it could be a family whereby, you know, they don't have the bus fares to come to RACH for essential medical appointments. And so we're seeing this as a family that aren't bringing their children for appointments. And actually, when we dig down a little bit deeper, it's not that they don't want to come for appointments, it's that they literally can't afford the 2 bus fares to get across town to come for the appointment. So we always have to dig a little bit deeper into what overtly might seem to be a neglectful situation and a neglectful impact on a child. You've also Sarah raised the whole thing around childhood obesity, and also children that aren't getting just a healthy diet per se. It might not necessarily be obesity. And often poverty has a lot to do with that. It's quite, it's easier to buy food that is tasty and, you know, frozen food. Well, there's nothing wrong with frozen food, but you know what I mean? Food that families might go for that is cheap and fills tummies, but actually what we know in terms of nutritional value, it's not what we would want children to be eating. So there's lots of reasons why it would appear that families might be making choices that might appear to be, from our perspective, neglectful of their children's needs. But actually, when you dig down a little bit deeper, it's because they're living in situations where there is poverty. And we need, the most important thing about that is to have the conversations with families, just what we've talked about. Sometimes those courageous conversations, but Anne's talked about as well, having those conversations right from the very beginning to try to get an understanding of what is life like, what is the lived experience of these children and these families, and how we can support them, sometimes to make the tiniest changes that will make the improvements for those children, and then they come out of what we would consider to be a neglectful situation. And I think that's fundamentally the important thing, having conversations with families right from the beginning, right at that early intervention stage, before we get to the end situation where we're talking about this child is suffering from the impact of poverty, of neglect within their lives. Poverty has an impact on that, but it's not the whole story.
Yeah, absolutely. Marie, anything from social work?
Yeah, excuse me. Yeah, just really to say that there's been a huge amount of kind of published research around the relationship between poverty and neglect over the years, in terms of kind of poverty affecting every aspect of a family's lives, and it can kind of increase the risk of harm around kind of poor mental health for parents, and then that kind of knock-on effect for children. We're really aware of kind of deep poverty and ongoing poverty, which is more damaging for children's safety and development than a low income or temporary difficulties. And it really is, I think, to go back and really echo what Fiona's already said in terms of kind of having those discussions. We do work with families who have been sanctioned in terms of the benefits, and we will, we have, supported them to contact the benefits agencies, DWP, to try and get, things back on track again. And that's really important. But we know that can also kind of impact on housing and kind of lead to some insecurities around that as well. We know that families very often are living in food banks, and and they're quite reliant on that, and that is then, I think, leading back to what Fiona and Sarah has already said around kind of diet and obesity, and the impact on children's health. But we have, and we will continue to support families and signpost families in terms of kind of poverty.
Yeah. Thanks, Marie. Lisa, anything from an education perspective around?
I don't think there's anything new to add to that, if I'm honest, Amy. I think we've covered that one there.
Yeah.
Again, it's back to that pointing them in the right direction for when you're having those conversations around who can help, the family learning services, our Fit Like Hub and early intervention services. So I suppose from school leaders' point of view, it's just being really clear on are you fully aware of the services that are available out there? There is documentation that's been circulated, and we can recirculate around the types of early intervention services that we can tap into as and encourage families to work with in order to help those situations. So it's just about making sure that you're fully informed as to what is out there and available, so that we can signpost often in the right direction.
Yeah, and I think that sometimes that's maybe the challenge, is just this knowing where to signpost and what is available. And I think that's something that we want to make sure that we cover within our new assessment and family strength and need assessment tool, that there are sort of an index, I guess, of places and services that can help with these various different challenges and environments. Yeah.
So the other point to make around that, Amy, particularly for our education colleagues on the call, is we're aware that Jo Aiken and her team and the Fit Like Hub had put together a document that was circulated for our education colleagues. I think it also went out to health and social work, just so that people were aware of the documentation. And that seems to be still being used, but Elaine Thompson, our QIM, is looking at tracking the pathways further. And I know, as you've just mentioned there, Amy, our team, when we look at fleshing out our family strengths and needs toolkit, we'll have links to other suggested organisations and so on. So hopefully there's not an issue with having these bits of information in 3 or 4 different places, as long as we make sure that staff are aware of them. So ongoing work, I suppose, from our perspective to make that better.
100%. Thank you. Anne?
Yeah, it's just to add to be mindful that children who live in poverty are more vulnerable to exploitation as well as they grow into teenage by these grooming gangs. So there is enough research to indicate that. So again, the need for early intervention, to be mindful of the impact and those terms.
Thanks. And I think most recently, we're seeing that on the rise as well here in the city around child criminal exploitation, particularly, and in a separate vein, CPC, or on behalf of CPC, there is some work going on in the background at the moment, just about our strategy and approach to CCE. Brilliant, thank you. So final question that we've got from the ones that were submitted was what can practitioners across the partnership do to ensure that there is good record keeping, especially where there are signs of cumulative neglect begin to become apparent? So I think the whole panel will probably have something to say on this one, but I'm going to start with Fiona or Sarah, just in terms of what's key to record as that first step.
Yeah, I Sarah, you please come in. I'll not go too long on this, but I suppose, you know, the power of a good chronology can never be underestimated. And I think when we're trying to identify cumulative neglect, which is of course something that happens over time, and sometimes it's the hardest thing to grab hold of, you know, and Anne's point earlier on around the definition of neglect, which is persistent. It's that persistent neglect, and as we know, the longer it goes on, the more damaging it is. I think the power of a good chronology is absolutely your key tool to demonstrate that. And remember, chronology is something where we can also evidence the good things that happen within a family, not just the bad things. But there's, you know, I could go on again about all the tools and that, but I'm going to come to Sarah, because I'd like to hear Sarah's contribution to this. It's really important.
Thanks, Fiona. I think sometimes when we think chronology, we think about writing down just what happened. But because we're all professionals who've got lots of experience of seeing lots of children across the board, children with various developmental abilities, we know what's normal and we know what's unusual. And it's being able to document when you think something just doesn't seem right, and describing it rather than necessarily interpreting it. Because interpretation, when we put that on colleagues, it feels like the onus is on you to decide if it's something to be concerned about or not. But what a chronology allows you to do is allows you just to describe what happened and be really factual, give an opinion about that event, but not have to give an opinion overall in that moment. So an example would be, you know, a good chronology should list what happened. So, you know, I had a discussion with mum, or you know, Daniel Pelka, the child that died following years of really awful abuse. You know, some of his chronology was really good, where the school teacher recognized that he was stealing food out of the bins, or that she brought a birthday cake in for the whole class and he ate most of it because he was so hungry. That kind of information is really, really valuable in the chronology. So describing what happened, describing who was present when that happened, who witnessed it, describing the reaction of the child, of the parent. So if you've had a conversation with the parent about a child's schoolwork never being done, for example, documenting what that parent's reaction is. If it's genuine concern of, oh gosh, you know, I've missed that, that's really positive, record that. If it's a so what, who cares, again, it's really concerning, but still record it. And then in the final column, record how it made you feel, because as a professional, your opinions on what happens is actually really valuable when it gets to that threshold of significant abuse and neglect, and we want to be able to do something about it. So an example I give, because it was just so unexpected, is a child that I saw for a comprehensive medical for cumulative neglect. He was a 12-year-old boy. He was the oldest of 3 children. Mum had 2 other children from with a new partner. She seemed to really like these other two children. She didn't like him, and that had been highlighted multiple times. He came to the medical examination with a social worker, a family support worker, and his mum, and one of his younger siblings who was 3 years old. And mum sat in there. There's 3 chairs next to my desk for parents to sit with their child, and there's 3 chairs. Some of you will have known this, on the other side of the room where professionals can sit and observe the medical examination. And mum sat in the middle seat, so the child had to sit next to his mum, and he sat with only half a buttock on the chair. There was no conscious effort, it was just very natural. So there was a half a chair distance between him and his mum. And I didn't note it initially. And then 3-year-old held up a drawing that she'd done, and she's like, "Mummy, Mummy, look!" And straight away, this mum was so engaging with this 3-year-old when she wasn't with this little boy. And so when mum got up to go to the back of, it's quite a large examination room that we've got, we're very lucky, when moved about 2 meters away to go and see this little girl's drawings, the family support worker came and sat next to this boy, and without even thinking, he just moved his whole body and fully sat on the chair. And that was a really, really important observation, because it's really abnormal. I see thousands of 12-year-old children. That's not a normal way to sit on a chair. And it was just being able to evidence and say the impact of this emotional abuse and neglect on this child is massive, and then to be able to put everybody else's chronology together and identify what the future predictions for this child are if we don't do something about it. So that was a very long-winded way. I think you're maybe looking for something a bit more succinct, but the power of a good chronology is documenting your opinion on what happened, not just what happened.
Yeah. No, I think it's a sad example, but it's a really good example of documenting that and getting that in a chronology. And I wonder if maybe you can just sort of move us further into sort of the joint chronologies and pulling all of that together and just how that.
I think that was a very good example. So I don't have anything more to add in terms of how that chronology is captured. But again, taking you through the continuum of the work that needs to be done if it comes to a point that we are to request a children's hearing because the family are not engaging and we're unsuccessful. These chronologies are important, but it's also important that it's factual, because if we go through that process, you as the health visitor or you as the educational practitioners will be called to court if you're going to a grounds hearing to stand by what you said. So capturing it accurately, and sometimes this can be maybe 3 years down the line you're going and you won't remember what you did, but you've accurately captured it. And if it's factual and you can stand by that, then that makes the process so much easier for you as a practitioner. I don't think I have anything more to add in terms of how to capture it, because I think Dr. Jarvis has explained that very well. But it's about why it's important through the whole process. It's important for the child. It's important for us as we take the family through that journey as well. I don't know, Marie, if you want to add anything more.
I think just to really highlight there, we've been working with a family over the last 3 months, undertaking an assessment here, and really when workers have gone back to look at the chronology, we've had information over the years from police, from housing, from health, from education, raising a number of concerns for this young lad. Looking at the chronology, it was coming in from all the agencies. Workers were able to go out and really to try and have some discussion with mum and really kind of highlighting, her poor mental health, the difficulties in the home environment. There was so much information really that had been shared by partner agencies and different workers over the years, that we had a fairly comprehensive chronology, and which gave us I suppose an indication to some of the patterns for this family over the years, and this wee boy's kind of lived experience and how, what his experience of childhood had been, and that's been really helpful for us, but also for us to be able to sit down with this mum and really kind of talk about kind of the impact all of this has had on this young lad.
Thanks, Marie. Is there any other comments around this subject? Fiona, you look like you want to say something.
Yeah, I do. I'm just thinking more and more about the work we're doing, the development work that we're doing for the the neglect tool. And you know, at the moment, of course, you know, like we've already said right from the beginning, we've got our GERFIC process, and that's where neglect, that's the journey we should take. But when we're starting to think about cumulative neglect, so that's the persistent, ongoing and an increasing impact on a child, I think that, you know, that's where our assessment tool is going to be a real golden nugget for us, because it's going to enable us to really get into that, articulating that assessment and the analysis. What does this mean for the child? What level of neglect are we talking about? Are we seeing any improvement? And this is what I think we need to have the conversations with families around, you know, what we have to have a shared language with them so that they understand what is it we want them to do? What changes are we looking for? There's no point in us knowing what we want to have changed and not sharing it with them, because, you know, it's like playing a game and you don't know the rules. And of course, with neglect, the majority of it is unintentional. Sometimes it's just the way the family circumstances are. We've talked about the impact of poverty and how that has that massive impact on all aspects of family life, from physical health to emotional health to mental health. So I think what this tool will be doing, and it's, you know, our approach in Aberdeen City is that we're writing it with a real non-judgmental approach. We're really thinking very carefully about the language. We want to be strength-based, we want to be supporting families, and we certainly don't want to be punitive and stigmatizing. And I think that what the tool will do is allow us to work with families to see what that progress is, and to make it really crystal clear to them, what do we want to achieve for you and your child, so that we can see that progress. And then if we're not making that progress, we then have a shared understanding of, you know, why we're not moving forward and why our concerns are raised. So I think, sorry, in a nutshell, I think the assessment tool is a really important development that we're going to bring to practitioners and families that will support the whole impact of cumulative neglect.
Yeah, absolutely. And we're very committed to making sure we do the best we can to get it right first time, appreciating that it'll go through various iterations, but using a focus group, testing it, coming back and really making sure that it's informed by practice and it becomes really useful, really useful tool to use. Okay, so that's our questions that we had submitted. Are there any questions from anyone, in any additional questions or any questions in response to what you've heard today? Mark, I'll come into you first.
Yeah, it's just to add onto the back of that. You know, from a police perspective, neglect cases are extremely hard to prove, and even if we do get enough evidence, there is a reluctance for the courts to proceed unless it meets an incredibly high threshold, and we totally rely on professional opinion, professional views, and what you see when you're out and about, which is so important in relation to record keeping, that you are recording time, date, locus, what you see, what's said, parents' reaction, and it allows us to build up that neglect case, or it allows us to build up a picture of actually what is happening in that child's life. And we might not get enough to take it to court, but it gives us enough information that we can share that information with social work and other partners to allow those safeguarding measures to be put in place.
Thanks, Mark. We've got a question in the Q&A. So does the panel feel there is an unconscious bias towards the remit of the child welfare and care being on the mother in the family, as opposed to both mother and father, being viewed as having responsibilities? Are there any existing toolkits or ways to address this? And she's given a few examples, thinking of cases of domestic abuse where the protective parent, usually the mother, is left with the majority of the care and responsibilities. Any of the panel want to take and try and answer this question in terms of unconscious bias?
I will acknowledge that that is a fact in the past, and even so, we are trying to address that. We've got enough training to say that, particularly in cases of domestic abuse, where most of the time, 99% of the time, it's the mother or the female that is the victim there, and she has care of the children. It is always her that is being approached. But at least in our teams and in social work, we are taking and we're beginning in the past couple of years been taking that approach of equally speaking to the perpetrator, the partner, the dad, whoever that person is, to help him understand his role in that. So I will admit that that has been the case, and I think that has not fully shifted. Some of it may be attributed because mum has care of the children, and we automatically first go to ensure that the children are safe, and therefore it is the mum that we are meeting in the first instance. But yes, there is an argument for actually we need to be holding the dad equally, or the partner, or whoever the person is, and we need to be having more conversations with them as well. So I will acknowledge that is needed more. At least when it comes to us, we are addressing that a bit more. Was there another part of the question? Sorry.
I'll just bring it. Sorry, I'll just bring it back up. It's in a separate frame. It was just around any toolkits or any tools that can sort of help with those conversations. With the only existing toolkits or ways to address this. Amy Martin's asked that question. Amy, are you happy with that answer? Is there anything further that you'd like to add for more clarification? Give her a moment. All good, thank you, Amy says. Great, thanks, Amy. Are there any more questions from anyone on the call about anything that's been discussed today or in response to?
Sorry, can I just say there is a Safe and Together training that kind of empowers people to address this imbalance more. I don't know how many of you have access to that. I know in social work that has been rolled out, but that might be a place, that we found really helpful. So I don't know if it's accessible to health and education, but something to take back.
Amy said yes, it's great training. I am aware that there is some Safe and Together training coming up. I think over the summer or after the summer. So once we finish the call, I'll make sure that an email goes out to those. It is usually circulated, but just to raise awareness of that opportunity that is available. Aaron, you've got your hand up. Do you want to come in?
Yeah, I'll try to be as brief as possible. I guess good food for thought in terms of chronologies from an adoption perspective, because we don't do those with our post-adoption order families, and maybe in some cases we should, because we're then establishing that patterns that are emerging for some of the families. Because I suppose the biggest thing we would see was probably the emotional neglect and abuse for some families, and obviously the front door services are the main port of call for child protection concerns, as we know, and we do work closely with colleagues in a lot of services, because our service pretty much is a voluntary service post-adoption. The families have to be wanting to engage with us, and many do, but we don't see many families for years, and then we see some for longer periods and then not. So I guess I'll take that back to the team. I suppose for our social work colleagues, it's important to note that on our recording system, it may look like there's a post-adoption case open, but sometimes that's adoption. The recording system isn't always clear. So I guess it's just about checking in with us as well, and us checking in with other services, because sometimes when we've been getting some concerns coming in, yes, there's parts of that's about adoption and maybe about supporting the family going forward, but a lot of that is maybe more immediate, and it is more of a child protection concern, but it's how we take that forward together and support the family maybe after those services are not involved. And I suppose it would be good to know just from any other services if there's anything we can do to raise awareness of our post-adoption service, and how we work together, just to highlight that going forward.
Thanks, Erin. I'll open it up to the panel for the response, but I think really just helpful for you to share that with everybody that's on the call. And I guess if anybody's got any thoughts on those not on the panel to share those. Anything from the panel in response to Erin's?
Yeah, I think just to say, absolutely, Erin, we absolutely get that. And if we do receive referrals into the team here where we know that a child or a young person has been adopted, then the adoption team are usually our first point of call, really, to see if there has been any post-adoption support, whether the parents, the adopted parents are engaging with that service, and whether there's been any training that's been offered, and whether there's been any, I suppose, additional information really that the adoption team and our colleagues there can provide. We have, worked alongside our colleagues in the adoption team before when there had been, welfare concerns or concerns around neglect, and so absolutely we would be looking for them to be, to be coming with us and working alongside with our parents.
Thanks, Marie, and thank you, Erin. Okay, so that brings us to the end of today's session. So thank you to everybody that's joined the call. If you haven't done so already, please, we've dropped the link to the survey in the chat, so please just take a moment to complete that. And finally, I'd just like to thank the panel for taking those questions today, and most of all, thank you to everybody that's joined the session. It has been recorded, and what we'll do is we'll get it up on our website in due course. The physical abuse one is already there, so there'll be a space on Aberdeen Protects for these Q&A panels and links to resources that we've got already existing. In the meantime, it's Friday, it's beautiful weather outside, and I hope that you get to enjoy some of it and it stays with us over the weekend. So thank you again, and please enjoy the rest of your day. Thank you.
Thank you.
Thanks, Amy.
Thank you.